Well, good afternoon, everyone, and welcome to our webinar today, Barriers to Access and Implementing Strategies for Patient-Centric Policies. We're really excited to be here. This panel will be exploring the important challenges to access faced by rare disease patients, as well as solutions that bring more patient-focused lens to these issues, as well as potential to lower patient costs and protect or enhance access to therapies and care. My name is Mike Egan, and I'm the Executive Director of the Rare Access Action Project, or RAP. RAP is an organization representing a coalition of patient, provider, life sciences, and other stakeholders with a focus on addressing the patient access challenges of our times. This year, RAP has reached its 10-year milestone since we formed as an ad hoc working group focused on shaping access for rare disease patients. My own rare patient journey began many years ago when my father called me at college to tell me that he had a preliminary diagnosis for a rare cancer. At the time, there were no treatments and very little hope. I lost my father about 6 months later, and that experience propelled me on the pathway that I hadn't anticipated, seeking solutions for patients with rare conditions and becoming focused on the barriers that keep patients from the innovations that can bring so much hope to an underserved population. 1 in 10 Americans has a rare disease, and there are approximately 10,000 currently identified rare diseases and conditions. Of those, approximately 5% have rare disease therapies with 1 or more therapeutic indications. 15% of diseases have a drug that has shown promise or is used off-label but lacks official approval for that specific indication. And yet, since the passage of the Orphan Drug Act in 1983, there have been 800 total approvals. Currently, for the form of cancer that affected my family, there are 20 approved therapies and combinations of therapies. And there are hundreds of clinical trials and even a wearable device meant to monitor both the treatment and disease progression. Yet, while we have made tremendous progress, including recent work with cell and gene therapies that provide hope for eventual cures, the unmet medical need is enormous. Currently, we have a time where there are many challenges to access, however, changes in programs and rules, uncertainty in coverage, that not only rare patients, but other patients must navigate as well. And we'll talk about that in just a few minutes. And it is in this current environment that many of our panelists serve in a variety of roles to seek solutions to today's access issues and lay the foundations for the next generations of patients. I'm pleased to introduce our panelists today. We had the opportunity to participate in a panel together at the World Orphan Disease Conference in June. And we thought, wouldn't it be interesting to reconvene the group for a broader audience and discuss navigating challenges and opportunities to offer solutions to those access issues, particularly as many of us are looking at the near-term horizon. We've got elections, we've got changes in both the federal government potentially, as well as at the state houses. And so this may be a really opportune time for us to come together and talk about these things. So I'd like to take a moment to introduce our panelists, then turn some time over to each of them to share their insights on key issues, offer their experiences and understanding of those issues. We've got some exciting study work that's been done. We've got a lot of work that has also gone on during this year, both legislatively and on the policy front, that our panelists can share with you. And then we'll offer time for a fireside style chat, a discussion on how rare disease communities can focus on solutions, what opportunities our panelists see in this current landscape, and while discussing those issues, open the questions to all of you. And please, during the workshop, if you have a question, please feel free to enter it into the chat, and we'll ask those questions live to the panelists. So first, I'd like to introduce our first panelist, Jason Slotnick. Jason is a policy advisor to the Rare Access Action Project and a principal and founding member of Health Policy Solutions in Washington, D.C. He represents both innovative biotech, pharmaceutical device, and diagnostic companies, and he specializes in counsels on the impact that Medicare and Medicaid coverage, payment, reimbursement, coding, and government policies have on patient access. So welcome, Jason. Alex Meixner. Alex is the Vice President of State Policy at the ALS Association. Prior to joining the ALS Association in 2022, Alex worked for over a decade at the American Heart Association, leading state and local advocacy campaigns and managing state advocacy staff. Before pivoting to state advocacy, Alex spent 8 years in Washington, D.C., where he worked for a nonprofit focused on international peacekeeping and genocide prevention. So welcome, Alex. And Melissa Horn. Melissa currently serves as the Director of State Legislative Affairs for the Arthritis Foundation, bringing more than 15 years of experience working in and around state and local government policy and nonprofit advocacy efforts at the state level. She's a fierce advocate for patients, and you'll find out why in just a few minutes as she shares a little bit more about her story. On a personal note, she is a 3-time cancer survivor, and Melissa knows firsthand the lifelong challenges of navigating chronic diseases. As the Director of State Legislative Affairs, she hopes to be a microphone for anyone who has a story to tell, to ensure people's experiences with arthritis are amplified as the Arthritis Foundation continues its mission to pursue a cure for America's #1 cause of disability through state policy change nationwide. So welcome, Melissa. And then I'm very pleased to welcome Dr. John Campbell. John is a health economist and a policy expert who serves as the Chief Science Officer for the National Pharmaceutical Council. In this role, he leads research that evaluates the real-world value of medicines to help shape fair insurance coverage and patient access. Before joining NPC, he served as the Senior Vice President for Health Economics at the Institute for Clinical and Economic Review, or ICER, and spent over a decade as a tenured associate professor at the University of Colorado. He holds a PhD in pharmaceutical outcomes research and a master's in biostatistics from the University of Washington. And he's published more than 250 scientific papers on drug pricing and medical value. So welcome, John. We're pleased to have all of you here today on the panel, and it's really an honor to get this panel back together after the wonderful opportunity that we had at World Orphan. So with that, I'll turn the time over. John, I'll turn it over first to you. And then we will go through the other panelists to introduce yourself further, talk about some of the current things that you've been exploring that have relevance to our discussion today, and lay the foundations for our fireside chat.
Great. Well, good afternoon, Mike and colleagues. So nice to be with you all. And as Mike already mentioned, my name is John Campbell. I run the research team as the Chief Science Officer here at the National Pharmaceutical Council. For those not familiar with NPC, National Pharmaceutical Council is a 70-plus-year-old health policy research organization. We envision a world where advances in science are accessible to patients, valued by society, and sustainably reimbursed by payers. And at NPC, we have a slogan that good policy begins with good evidence. And I'm leading the charge at NPC alongside my research colleagues to develop that good evidence. A policy environment that disincentivizes innovation in rare diseases is one that we're concerned about, and I think we'll have conversation about today, Mike. You mentioned you set the stage already about where we are today, and I think that's one where a number of patients have hope based on therapies available to them, patients living with rare disease, and yet we still have a lot of progress to make, and there are many patients that live with rare disease and do not have opportunity for therapy or improvements. So we're seeking an environment that continues to sustain innovation moving forward. My main statement in the opener here for this afternoon is that NPC has studied government price regulations in various forms and the unintended consequences of government price regulation. And we worry that one of the key unintended consequences can be that government price regulations can harm patients' access to medicines, both today and in the future. So I just wanted to give you three anecdotes on that before handing it over to the other panelists. The first was work that we did in the Inflation Reduction Act. For those not familiar, IRA or the Inflation Reduction Act has been with us now for about 4 years. Was passed in signed into law in August of 2022. And the National Pharmaceutical Council conducted research back in early 2025 where we observed a decline in the percentage of drugs with a first orphan indication that later received a second designation. And those are the very kinds of medicines that hit home, perhaps for this audience. Why does that kind of research matter? Well, those were the very kinds of medicines that could be included in the drug price negotiation program under IRA before we had orphan cures that was passed in mid 2025. And so the research we conducted back in early 2025 was cited in congressional testimony. And now we have orphan cures that keeps medicines with only orphan indications outside of Medicare's price regulation. We continue to conduct evidence-based approaches to understanding the patient impacts of orphan cures since it became law, and happy to share in the chat some resources that we put out since orphan cures on some of those descriptive patient impacts. But there's more work that can be done there as we learn and get more evidence under our belt. The second anecdote is at the state level, within prescription drug affordability boards. NPC research there compared states with a UPL authority to other states regarding current access to medicines, prescription drug affordability boards, and medicines that have been targeted by those groups. So that UPL stands for Upper Payment Limit, and this is an authority that's currently available purportedly for 4 states. So we looked at those states and compared them to other states in terms of access to certain select medications. And what did we find? We found that despite states' intentions to improve access and affordability, these PDABs can actually be associated with access barriers for patients without guaranteeing drugs will be more affordable to patients at the pharmacy counter. So although we haven't seen UPLs be effectuated yet, these are some of the concerns that we'll be watching as those states continue down those processes. And finally, the third anecdote is within mandatory international reference pricing. You may have heard of Medicare's Globe and Guard. These are mandatory versions of international reference pricing that require manufacturers to participate within the Part D, Medicare Part D and Part B programs. So the Medicare medicines that you would fill at the pharmacy and those that you would get through your physician. And NPC research here has suggested that about 50% of drugs that may be within these proposed models have indications for rare disease. And that's a large number. And so we want to follow that work. These 2 models, Globe and Guard, are proposed. They are not finalized today, and so we'll be continuing to watch as those 2 proposals emerge and potentially become finalized. So why does this work matter? It's really because additional disincentives to innovate for patients living with rare disease will only slow patient access. So with those 3 things in mind, I will hand it back to Mike and look forward to the discussion and further questions. Thanks, Mike.
Thank you, John. Melissa?
Sure. So I know that it was already mentioned kind of my personal experience as a 3-time cancer survivor. Just to note, I always say that rare is more common than everyone thinks because all of the cancers that I had were considered rare. And it really started with having lymphoma in high school. And actually my only symptom was losing my voice. So I like to say that I've gotten it back, but I'm also using it to hopefully make things a little bit better for other patients that are living with different types of diseases, whether they're considered rare or more common. The other aspect is a lot of diseases overlap. So a lot of our nonprofit associations work simultaneously in coalitions. In fact, my Past history of employment also included the Heart Association with Alex, and we both worked in Chicago for some time. But we've worked on a lot of the same issues across the board in many different states, and that's where my focus has predominantly been, is working on the state level, in working with patient communities to make sure that we are really relaying the real life experiences of patients, whether that's in trying to get access to health insurance coverage or trying to reform and improve insurance coverage. So I would say, some of the big issues already were talked about whenever it comes to affordability of prescriptions, and certainly we're active in the Prescription Drug Affordability Board conversations. And being a resident of Maryland, where the first PDAB was created, I will express my personal frustration too as a resident and seeing how much that costs to put together a PDAB versus what the results have yielded, I think since 2018. I'd rather see the legislature, just personally, again, personal hat, focus on real life changes for patients to really pass on the savings for drug rebates, for example, or really make sure that affordability is addressed through ensuring that patients can utilize assistance for affording their medications, like what we see with copay accumulators. Thankfully, Maryland has already addressed that, but only 26 states have really looked at policies and made changes to their laws. I think pushing it to the PDABs and outside of the legislature often creates that kind of problem and that gap in making change quicker and really more direct to the patients. And then we see things like maximizers where, assistance is trying to be spread out across the course of a year and not sticking with that patient, regardless of where they live in the nation. Similar to the different conversations around direct to consumer and most favored nation with drug pricing. We want to make sure, though, regardless of what price the patient pays, regardless of the retail price of the drug, or if they're using assistance to pay for it, that the patient's cost is counted towards their deductible and out-of-pocket costs. Because that is really, in a nutshell, what we're talking about here, is patients end up in what I call copay quicksand. So they might have insurance, but they don't really know how to budget for their healthcare. And whenever you have these conditions, especially those that are rare, you're spending a lot of the time trying to figure out what you have and how best to treat it and how to stay stable on those medications and be able to afford them. So whenever it comes to some of the law changes and policies that we've worked on with the Arthritis Foundation and other partners, we really try to keep that in mind. We know that there's a lot of changes to insurance access with Medicaid and the work requirements that are coming into play in 2027. And as the leading cause of disability, we want to make sure our patients get onto health insurance plans and not pushed onto really expensive, high premium, high deductible plans. But also that, again, if they need that assistance to cover their medications, that they can do that without running into some of these schemes with accumulators, AFPs, alternative funding programs, and whatever the insurers come up with next in terms of kind of these catches where they just sink further and into debt and into affordability problems. The last area that I wanted to talk about too, and just note is, we've really worked on innovation policy. We want to better diagnose our patients and our patient community, but also find the treatment that works. We already know that it can take 2 to 3 years for a patient that's living with arthritis, regardless of the form of arthritis, to get diagnosed. But then it's also this back and forth of feeling like a guinea pig to find a treatment that works. But now we have biomarker tests where we can find out not just the diagnosis of a disease like arthritis, especially RA. There's I think five different tests now for biomarkers, but also what treatment would work. So they don't have to keep failing on different medications that have really bad side effects and are super expensive before they get to the one that will work best for their body. Because just because you're diagnosed with a disease and you might share it with another patient with the same exact disease doesn't mean that your body is going to react to that treatment the same way. So I think we're really on the leading edge here of potential, but we need to make sure that insurance is covering this type of innovation and really taking into account the real life experiences, again, how hard it is to get diagnosed and how hard it is to find a treatment that works whenever we're looking at policy solutions. So that's been my area of focus.
Terrific. Thank you, Melissa. Alex.
Great. Well, Mike, thank you. And thanks everyone for joining us today. So again, I work for the ALS Association, and much like Melissa, we've got a focus on helping the patients we serve access and afford the therapies that they need. And we kind of take that in a couple of different buckets. One is trying to grow the aperture, grow the pipeline of research dollars to help create more therapies. When we're talking about ALS, it's a fairly well-known rare disease, and yet there are exactly count them, three FDA-approved therapies on the market for ALS. That is not a lot. Certainly the folks we serve are always asking, when are we going to get to a cure? When can we find something that'll work for me? If you're not familiar with ALS, it takes 1 to 2 years to diagnose. It then leaves you with an average life expectancy of 2 to 5 years. But some folks can go a little bit longer. So there's a lot of hope that exists within this community that the pace we see advancing in biomedical science, in genetic science, in research is going to produce a cure that not only will help folks like them at some indeterminate future point, but could help them next year, next 2 years from now, whatever it might be. And so there's a real focus on, again, widening that aperture of research investment. And we do that by working with the federal government to try to appropriate more dollars, and more recently working with state governments. State governments don't typically fund a lot of biomedical research, but that's changing. If we're looking at only my little slice of the pie for ALS research, 2 years ago, the total aggregate state investment in ALS research was around $5 million. Last year was around $10 million. This year it's around $20 million. Still long way to go to get the impact and scale we need, but it's definitely moving in the right direction. And we've seen some very positive things like Texas last year, having a ballot initiative go to the voters and then putting aside $3 billion towards neurodegenerative research. There's a ballot initiative going to the voters in California this year that, not to be outdone by Texas, would set aside $8.5 billion, and a bill moving through the legislature in California that is probably not going to make it through this year before they gavel out in 2 weeks, but is going to come back next year with any luck, that would invest even more. So those are just a few of the examples of where we've seen states kind of stepping into the breach, where there might be a little less certainty, a little less security of the long-term presence of federal research dollars, and states saying, hey, we want to do this too. We want to support our in-state industry, and we want to get towards a cure. So that's part of it. Again, speeding towards new cures. The other part of it is, of course, making sure that once those cures are found, people can actually get them and afford them. It's access and affordability. You can't choose between both. And that's one of the reasons we don't particularly like PDABs. It's preferencing affordability, but at the cost of access. And that doesn't help folks living with ALS, and it doesn't help a lot of folks living with rare disease. So, as we're looking at that, how can we make sure that states and federal governments can put in place laws, regulations that will stop bad practices from, folks in the insurance industry who might otherwise deny access to a drug, who might say, no, you can't have the oral version of this drug that you can take in your home and have good efficacy of actually taking. You have to take the IV version because there's a new generic on the market, even though you're in a 200-pound wheelchair with real mobility issues, and limiting you to that is going to necessarily mean that you're going to miss some of your doses. It means looking at companies that might say, you've had a drug approved via the accelerated approval pathway, but we as an insurer are going to choose to say that that's experimental, and therefore we're not going to cover it. And we have seen that over and over again, unfortunately. The newest of these 3 FDA-approved drugs, Qalsody, which has been approved just for 2 years or so now, it has been shown not only to stop progression of ALS, which is a progressive neurodegenerative disease, but actually to restore function. So folks that couldn't walk can walk. Folks that couldn't talk after some dosage and some time can talk. Now, this drug only impacts and is only able to benefit about 1.5% of the full ALS population because it targets just one genetic version. That said, even in that small population, we've seen folks that have been put on this drug by their doctor and then they've had a change in their insurance, and their new insurer will say, no, that's experimental. We're taking it off, or we're taking you off. Now we appeal. We've helped them appeal. We're in fact next week going to be launching a new platform to help folks battle these battles. The problem being, if you have to, fight your insurance company for, let's say, a month, 2 months, 3 months, if you're talking a progressive disease, it might be the case, and in fact, in reality, has been the case in this last year. Folks have been taken off this drug. They've got to wait a couple of months until their denials are overturned. And when they're put back on it, they can no longer walk. They can no longer use their arms. They can no longer do the things that they could do had they been kept on it the full time. So there's a lot of whack-a-mole that I think we in the patient advocacy space, and I see Melissa nodding because I know she has to do the same, always have to play with payers where they find new ways to try to limit access in the name of cost efficiency. And hey, we're all for cheaper drugs, but we really have to keep a sharp eye on those access issues because they're not abstract. They're not, data points on a graph. They're real people's lives. And if we are not sharp about maintaining access, we know that in reality, they're going to lose it. And I'll stop there.
Well, thank you, Alex. Jason, we'll turn some time over to you.
Well, thank you, everybody. Alex, hearing that story about that Qalsody patients really breaks should break everybody's heart, but really, it really is so sad to hear that is what's going on, and is in part what has inspired us all, even those on the webinar this afternoon, to do what we do. And as somebody said, as a long-term swamp creature like Mike is, right, it takes a village to sort of get things done around here. And your story is why we all spend more hours than than there are in the day monitoring the NIH and the FDA and CMS and the Congress and all kinds of other state policies to create an environment that promotes innovation and stimulates and rewards innovation, and more importantly, gets at access and reducing those barriers. And so, as Mike said, I've been working with RAP since its inception on doing just that, right? Following all of those entities and trying to shape policy to do just that, which is promote and reward access. And unfortunately, Alex, I agree with you. It's a whack-a-mole. Every day is a different flavor. And really appreciate the work that you and Melissa are doing as advocates and John as researchers, and just sort of prove the point that at some point, hopefully the whack-a-mole ends, but I suspect that it won't. So it's great to be with you guys today. And Mike, I'll turn it back to you to sort of get the conversation going.
Great. Thank you, Jason. And thank you to all of you for your introductions. There's a number of points that we could dig into from what everybody's talked about. I mean, there's just so much complexity that's swirling around right now for patients. And Melissa, you kind of actually pointed to something that I think I want to open up on. We've heard not only from patients, but their providers about the exhaustion and the exhaustion issue when it comes to navigating prior authorizations, documentation. Did they take the right test at the right time? Did they go through the right sequence of medicines, even though they may have a genetic, let's say, delete or something that makes two or maybe more of them not work as well? Talk to us a little bit about patient exhaustion just before we get started into some of the substance and what that means to you.
Absolutely. And you'll hear kind of my little mantras of like copay quicksand and how exhausting that is. Like you feel like you're making headway and then you just sink further. And as a patient, it's just already exhausting to have to navigate a diagnosis, but then also to have to figure out how to afford it. But then let's say you can afford it and you do go through it, and you've worked with your doctor for getting that prescription, but then you go through these other delay to pay issues with your insurer, where they might again have that step therapy requirement where you have to fail first on a medication before you can get to the one that you already know will work for you. again, with biomarker testing, that helps us figure out already in advance that we know that, hey, this Humira is not going to work for me because of a certain protein in my blood. But your insurer has, let's say, a step therapy protocol that says you have to. Humira is our choice, and I hate to call out certain drug names because this could be any drug. It doesn't matter. You have to go and try that one first because that's our preferred drug. Before you can get to the one that your doctor knows and you know from your blood will work better for you. So that's a delay. That's a delay to pay out a claim. The second area, which is probably like even more egregious, is this area around prior authorizations. And we're seeing it even more so in drugs that are less expensive. The whole idea of utilization management protocols is to reduce like higher cost spends on drugs or diagnostics that might not be as needed in the eyes of the insurer. But again, this takes away the decision point from the patient and the doctor who have already made this assessment on what will work for that patient and that condition and treatment plan. So whenever you're going through prior authorization denials, I mean, I'll just give an example for myself personally. I currently have thyroid cancer. I have thyroid cancer because of the treatment that I had for lymphoma and then breast cancer. It led to this removal of my thyroid, and now I take levothyroxine every day to replace the function of my thyroid because I don't have one. We are not lizards. We can't grow back body parts. So I have to have a medication that keeps me alive every day that I take. It's a very inexpensive drug. However, levothyroxine is a hormone-based drug, so often my dosage changes. I'm currently going through like some weight loss protocols, and every time my weight decreases, I have to change the dosage of my levothyroxine. Every time this changes, every month, I have to get put back into a prior auth little scheme where the insurer wants to delay to pay out that coverage for me, even though it is a medically necessary drug. If I don't take it on time every day, I could end up in the hospital with a stroke. And again, it's an inexpensive drug. It's less than $100. But again, because my dosage changed, it flipped me back into another approval. It's the same drug, it's the same price, it's the same estimate, but we're still seeing these kind of delay to pay tactics by insurers. And even within our own plan, I'm not on a high deductible plan. I'm not on, some of these plans that might even have additional barriers in their utilization management protocols. But it is exhausting as a patient to go and fight on a drug that is like less than $100 to get it approved for a condition that I will have the rest of my life. And if I'm going through that for a drug that is just one pill, it's literally like the tiniest pill that you could probably even take. What are patients that are going through more disabling conditions going through? For more expensive medications, for more medications and prescriptions and diagnostics that are more invasive, like infusions and things like that, where it requires a hospital stay. This is just a simple pill. So you do start to see how laborsome this can be to manage your condition. And we hear from our patients in the arthritis community often that they would love, their idea of success is to forget that they have the disease. They would love to live with it. They're not looking for a cure. That's the wrong goalpost. They know this is a chronic condition and they're living with it. It's not disappearing. They just want to live with it in a way where it's not preventing them from saying yes to the things they want to do in their life, whether that's go to work, do something with their friends or family, or just complete any everyday task. Just even get out of bed and be able to do the things that they want to do. So yeah, I mean, the exhaustion is real on behalf of the patients, and certainly navigating your insurance can feel like a second job, honestly. So hopefully we can work on some of these law changes that will make those utilization management protocols easier to navigate because we understand the idea of reducing cost. That's everyone's goal. I don't know any stakeholder in this discussion, be it the patient, the provider, the insurer, the government, that wants to spend more, that wants to spend more money, that wants to spend more time on any of these things. So that's the kind of exhaustion that I feel like I'm a broken record on, but hopefully we'll get into the minds of policymakers as we make these decisions.
So Alex, you also brought up a point, and so I'm going to ask you the question, then I'm going to open it up for John and Jason as well. There's a balance here that needs to be struck. And I know we talked about this a few weeks ago when we were together in Chicago a little bit about the balance between lowering patient costs and ensuring patient access. Can you talk to me a little bit, or to all of us, a little bit more about how do you approach some of these issues then with that perspective that kind of brings a patient lens to it? And then how do we strike those balances as we look at things like PDAP, we look at IRA implementation, we look at, MFN and some of the other issue areas that we're going to be discussing here in a few minutes?
Sure. So, I mean, again, to easily agreed to goals, lower prices and increase access. Who's against it, right? And yet, when you try to put it into reality, there are trade-offs. So, as we're looking at it from our patient's perspective, or the folks we serve's perspective, if you're living with ALS, you are going to go through every dollar you've got. You're going to go through your savings, your home equity, your kids' college fund, your retirement. You're going to do a GoFundMe. You're going to do all that stuff, and you're still going to be short. That's the reality of this disease. Within that reality, lowering a percent cost of one specific drug might be a little bit helpful, but it's not going to change your financial future. Lowering access to that drug, or worse still, changing the incentive structure in such a way that that drug would never have been researched or developed or approved in the first place, that's much, much more significant. So again, just from the perspective of serving the folks living with ALS, there's 30 some thousand of them in the US at any given time. Every 90 minutes, somebody is diagnosed and someone else dies from ALS. From their perspective, the incremental benefit of dropping a drug price a little bit, especially when most of that cost is borne by the payers, and we don't want to be blind to that. They pay quite a significant percentage, but dropping that cost an incremental bit is not going to be life changing for that family. Disincentivizing the research and development of that drug in the first place, that is life-changing and potentially life-destroying. That's what we want to guard against. So yes, we're absolutely in favor of reducing costs, especially the out-of-pocket burden faced by the families that are least able to absorb those costs. And that's why things like copay accumulator bills, yes, we wholeheartedly support those, and many other measures. Failed first bills, you name it. There are things that can be done at a federal level, at a state level, to help ensure that the cost burden does not fall on the end user who is the least able to absorb it. But if you're looking at bigger structural fixes for costs, it has to be in context of that trade-off and what is the impact for the patient going to be, not just spreadsheet logic.
Mm-hmm. Jason and John, I'd like to open up the discussion to both of you.
John, go ahead.
Okay, thank you, Jason. Just to build off of that, Mike, if you don't mind, I think two thoughts. One, it's important to recognize that medicines are a component of healthcare costs at large. So talking about beyond whether it's the patient or the payer that's paying, they are a slice of that pie, and yet recent data from IQVIA suggests that slice is about 10%. The net cost going back to manufacturers is about 10% of overall healthcare costs. And so I think we can start to discuss, whether we get good value from that 10% of the slice versus the other 90% of cost for healthcare. But so that's like sort of the big discussion that we could have. But perhaps even more important for today's conversation is it's important to recognize that patients should benefit from the more than 50% of what we call drug spending here in the US, because that more than 50% goes to an entity outside of the manufacturer who is advancing that medicine and bringing that medicine to patients. So we have a very complicated supply chain here in the U.S., and I know 340B has been a hot topic in the policy spheres today, and that's one of the challenges in the supply chain. But again, however we spin that component, getting more of those dollars back into patients' hands would be helpful as a potential solution. And Jason may have some thoughts on that too.
So John, before I go, are you saying that for every dollar that a manufacturer should recognize on a sale of a drug, 50 cents of that is lost in the channel?
Well, yeah, 50% of drug spending doesn't go back to manufacturers. That's right.
So it's lost in distributors and in health plans and whatever it may be.
Yeah, some of it's going to go to pharmacy benefit managers who will keep a cut. We've also been in the 340B program. That's also another program where hospitals end up enjoying quite a bit from the value of medicines and extracting that value and keeping some of that for themselves.
Yeah, so the reason why I pick up on that is something that Mike and I have talked a lot, and even we did, like Mike said, in Boston, is sort of what is so starting at the top is what is the purpose really and concept of insurance, right? And spreading risk and how that should be done from either the government's perspective or even the commercial payer perspective, right? And that's sort of each has different responsibilities. But at the end of the day, insurance should be about spreading risk and not shifting risk. And so from that concept, we've talked about, right, everything you guys are describing about prior auth, whatever, is an attempt to shift risk and not as an attempt to spread risk. And I've said way back when, so once I started in this business a long time ago, which patient, which family wouldn't spend a little bit more? Now that little bit more is a story, right? On premiums in an annual way to sort of self-insure against the catastrophic bankruptcy that Alex describes for his ALS patients. And it gets very complicated about spreading risk. But I do think that spreading the risk is a way you can lower patient costs, you can appropriately manage and still stimulate access. But more importantly, when you have a predictable insurance and spreading a risk system, you can then build upon it a system that rewards and stimulates innovation, that drives competition, and therefore continues to do what only competition can do, which is, right, drive down costs, but also then reward the next generation of therapies, right? As somebody who's been very close to ALS for personal reasons knows Alex's not story, but statement of facts. Lou Gehrig basically has the same treatments that current ALS patients have regarding ALS, and it's just been a crime. And so what we've tried to think about here in the swamp is sort of how do you do all of that within one? Is it a reinsurance policy? Is it getting at prior auth and moving that away and having better management of upstream costs for patients, moving to cheaper sites of care? So to me, Mike, the answer of how do we achieve that very hard to achieve balance of lowering patient costs and increasing access is really tucked into that. What kind of health insurance system do we want? How do we want to strike those balances of appropriate care at the appropriate site without it being a single payer that will sort of create all kinds of other issues? And I think that's been the struggle we've had for many, many years in DC. John's statistics it show us that it's getting worse over time. I think we've all experienced enough to know that it is. And the question that sits in all of our minds is, when is there a tipping point and where do we tip to? And how do we make sure as a group here that when it tips, rare disease patients aren't on when it tips, it doesn't tip on them. Right, they could sort of not be underneath whatever tips on them. So, we'll continue to have the conversations, and Mike, maybe we can tease out a couple of ideas that help there, but we shall see.
Yeah, I think that's a very interesting kind of way to look at it, Jason, because we talk a lot about benefit design and improving benefit design, looking at that foundation that you talked about. Yet a lot of the solutions seem to go the opposite direction. I'll go back to what Alex said. It seems like a lot of the things that we've been analyzing lately focus on kind of all of it running downhill to the patient. The patient absorbs the cost. The patient, absorbs the access challenges. The patient kind of gets put in there because that risk gets shifted. For example, in July, we released our paper on PDAB in terms of trying to follow how a UPL would actually work through the system, right? And lo and behold, what did we find? The costs shifted from their insurance, the plans, the PBMs, to the patient and the pharmacist. And that's basically kind of where a PDAB UPL or upper payment limit would kind of pull the lever. And so again, the patient, faces the challenge with coverage. Will their plan cover it after that? Will they not? Who makes up the difference? If the pharmacy can't stock it or cover it, then the patient goes without potentially. How do we shift to that kind of bigger discussion? I think that's a question that Jason kind of teed up for us. And John, you've alluded to. How do we shift to those issues that can really drive patient affordability, patient access, and kind of an innovation-rich environment that we kind of talked around here for the last few minutes? John, I'll turn it over to you if you want to start.
Sure. Not a easy problem to solve, Mike. But I will share this. So, I think oftentimes we think about in healthcare, we're doing things to patients and not with patients. And I think having that shift in mindset could be helpful here. I'm an advocate for value-based solutions in healthcare. And I think having the patient voice be centered when we're talking about value, I think is just central to what we need to do in terms of some solutions within the pharmaceutical space and perhaps other parts of healthcare too. So thinking about, at NPC, we say that value assessment itself should be viewed as a tool, not a rule, and that there's not one answer to value. Just as there is not one patient story, there are multiple stories, and we've heard a few today, but all of those are important experiences, the lived experiences, to bring into an understanding of a value and have that understanding be driving our incentives and our competition in the marketplace. So we've done some work at NPC on understanding unmet need as an example, and have collaborated with the National Health Council and University of Colorado to bring in patients and caregivers and understand what concerns they have as a concept under unmet need. And that, perhaps not shockingly, differs from a concept of unmet need that FDA or CMS has. They have a more standard clinical understanding of unmet need, but when you talk to patients and caregivers and you hear from them, you often get the very kinds of barriers that they're navigating in that system that are central to them in their unmet need. And so even those kinds of understandings, I think, are steps we can take. But in the end, keeping the patient at the center is got to be a part of this, Mike.
Melissa, jump in.
Absolutely. So I couldn't agree more in keeping the patient at the center and really talking about real life experiences. And that includes those who haven't been diagnosed with a rare disease or a chronic disease, or don't utilize their insurance coverage or participate in the health system because probably they're not understanding how it actually works. And that literacy and understanding the insurance system is no small feat. It is obviously very complex. And I say this often to other people who haven't experienced something like cancer or one of these diseases that we're talking about that can be so devastating, is, spoiler alert, no one's getting out of this life alive. And you'll be lucky if you don't ever have that kind of either firsthand or secondhand experience of someone who has to use the health system pretty rigorously. So I know that we're kind of going backwards to these like foundations of healthcare access and affordability. But I think it's important because we are on this precipice. It's a very important moment in our time. especially in America, in talking about this. Because we do have these new work requirements on Medicaid, for example. I think that will be a predominant um, issue for us all to focus on in the next 5 to 10 years, to be frank, is about people's ability to utilize healthcare. And that is based on now their ability to work. Well, what does that mean? Like you're basically weighing people's lives here. And you're really relying on them to understand how to navigate the system. And whenever you're putting that pressure on the most vulnerable populations, those that don't have the income that can buy a plan that has all the bells and whistles and has the coverage for biomarker testing. So if you do get diagnosed with something, you're not falling through the cracks here. Those systems, whenever you look at like Medicaid and this, that's the largest health plan in America still. I think 1 out of every 5 Americans is on Medicaid. When you have that system that is totally going through major reform right now, this is the time to have these conversations about what it is really like for a patient navigating care and really understanding what your healthcare coverage is and what it isn't. Because you might find yourself uninsured completely because you can't work those 80 hours. You might find yourself insured but not seeing the full benefits. You're underinsured. You might find yourself fully insured, but you're not utilizing the benefits to its max, or you're denied benefits because of all these protocols, all the over complexity of the system. Or in my opinion, you find yourself healthy and not needing it, and kind of in this false sense of security that you won't have to. And the reality is we all will have to. So we all need to be engaged in the conversation at every level, whether you're sick, whether you're healthy, whether you're undiagnosed or have been diagnosed. All of this, you need to be part of the conversation. And I think that's how you really come into play and analyze the changes that need to be made to the system to make it more accessible and make it more affordable. So stay engaged, participate, speak up.
Alex, would you like to weigh in on some of the areas that ALS is exploring as well? I mean, Jason laid some foundations of looking at risk pools, looking at ways to bring people together to spread out the costs and build a more affordable system. I know ALS, you've been looking at some of these specific areas as well. Are there some thoughts or guidance that you would share with us?
Sure. And, I'll start by piggybacking on what Melissa was talking about with regard to Medicaid. I used a phrase earlier, spreadsheet logic, and I think that phrase pretty well describes how a lot of the conversations in state houses, at agencies in DC are going when it comes to Medicaid, and it's how do we bend the curve by reducing enrollment. And a lot of that is coming down to adding administrative burden for the folks that might not be able to figure out how to keep up with their recertifications that they're working, or whatever the trapdoor might be. And there's lots that are being built into the system right now. As we're looking at that, the need to keep, again, to Melissa's point, an individual patient's perspective, and every patient has a different perspective, right? But in aggregate, they start to rhyme pretty significantly. Keeping those perspectives in those conversations is so key, because it is the antidote to that spreadsheet-driven logic of, but we've got a target to hit, we've got to find a way to hit it. And yet something that can seem fair, if hard but fair in abstract, can seem unfair, unworkable, and unacceptable when it's brought into the sharp relief of a bright light and a specific story. So I'd start with that. Beyond that, to your question, Mike, of looking at some other areas that we're trying to find to solve this, some of it is, again, working all of the regulatory options that exist. We've talked a bit about the legislative, trying to do things like pass copay accumulator bills, work against PDAB bills, pass bills to strengthen regulation and oversight of PBMs, et cetera, et cetera. But even once laws are in place, the regulation and implementation of them is never perfect. So, for instance, we've seen more than a few folks that have been tripped up by employer-based plans that are regulated under ERISA. So those, if you've got an issue with those, you need to go to the Federal Department of Labor and start that process. That is not typically where public health conversations live, right? We don't, in the public health community, all know a million people that work at labor. If you ask me for a contact at HHS, I could probably help you out. Labor, not so much, and that's pretty common. But we need to be following these crumbs to get to where folks have the authority to make these decisions. Again, I'll use another example. For ALS, it's one of two conditions that has a federal fast lane to get Medicare coverage under the age of 65 without a 2-year wait, right? So the other is end-stage renal disease for that, or for ALS. The day after, for ALS anyway, the day after you finally get your diagnosis, you can be covered by Medicare. And in many states, we've passed laws to ensure that when you get your Medicare coverage, even if you're under 65, you've got a 6-month window to buy Medigap, Medicare supplemental coverage, which you're going to need because your costs are going to be high. For the over 65 population, they've got a 6-month window automatically where they can get coverage. Payers have to sell them a policy. They're not allowed to take anything into their medical underwriting with regard to pre-existing conditions. So they basically have to give you a fair price. For the under 65s, they don't have to do that. The reason I bring this up in terms of an implementation and kind of regulation conversation, I was speaking maybe 3 weeks ago, a month ago, to a woman in Indiana whose mother has been diagnosed with ALS, just got her diagnosis confirmed in June. Applied for Medicare, got the letter back in mid-July saying, yes, you are officially Social Security disabled and you're enrolled in Medicare, but they backdated her enrollment to January 1. The impact of that was Indiana, we helped pass a law 2 years ago to ensure that under 65s, this woman is under 65, have that 6-month window, even if they're under 65, to buy affordable Medigap. Because she was backdated 6.5 months, her window had already expired and no payer was required to sell her a plan or sell her an affordable plan. That's an example of that wasn't the intent of the law. I'm sure, in fact, the folks at SSA were thinking, oh, we're doing you a favor. You can, retroactively get some benefit, but the impact for her is going to be, not so great. And again, that's on the regulatory side, on the implementation side, where we need to make sure that not only do we pass these laws that we've been talking about at the state and federal level, but that they're being faithfully implemented and we are seeking out those individual patient stories that might sound unique, but probably aren't. And if we can fix this for this woman in Indiana, probably we can fix it for other people that this is going to become an issue for. So again, it kind of gets back to that earlier point that we need to be seeking out individual stories, to Melissa's point earlier, empowering them to use their voice, be their voice when they don't have one, and ensure that their perspective is in all of these conversations and don't get overtaken by that spreadsheet logic.
And details matter. The details matter. That's some story, Alex. Go ahead, Mike. Sorry.
Well, I was just going to say, Alex, to your point that bringing in those patient stories, those experiences are real life and lived. And sometimes policymakers look at me and said, oh my gosh, I just had no idea. I had no idea. I thought we were fixing it until they hear what happened on the other end. And a wrinkle is no longer a wrinkle or on a spreadsheet. A wrinkle is a person that's sitting in front of them. So whether it's, in Congress on the Hill, Jason, or an agency, or at the state level where, patients have even more access to policymakers, that wrinkle becomes a face and a person and an experience. So I know we're running up on time. I would just turn it back to all of you for a quick close, and then we will wrap up. So Melissa, do you want to jump in first?
Sure. I feel like I've gotten most of my nuggets out in my comments thus far. But again, I'd reiterate, sharing the patient perspectives, especially for the communities that you're representing, but also as a, individual yourself, whether you have a disease or don't have a disease, speak up for these changes, because lawmakers need to hear not just from the people that are affected, but for the people that care about them. And that includes yourself. You might be in that bunch sooner than later. And it's unfair to say this, but there's no such thing as immortal. So no one is unaffected in a way. Everyone has to utilize the healthcare system, so try to make it better for everyone and speak up and share your experiences, especially if you are experiencing a barrier to care or access or affordability. That is part of what will make it better, because the real experiences, like Alex was so eloquently putting together there, is what is going to make for the best policy change. And we have to keep adjusting it. Don't get deflated. It's a work in progress always. So let's all chip in and make it better.
Thanks, Melissa. Alex?
Yeah, I'll just be brief and say, personal stories are the antidote to complexity. The challenge that I've seen so many lawmakers throw up their hands at is the complexity of the healthcare system, the complexity of the financing behind it. It just becomes a this is all too much moment, especially when it's 2 in the morning and they got to get the bill done and it's taking this long because no one is fully in agreement. Those are the moments when they can give up and just say, fine, or they can stick forward and say, no, 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 no. We need this. This topic might be complex, but our goals are simple: ensuring access and affordability. If we don't know that we're not doing that, then we're not doing the right thing. And so keeping that front of mind, giving them things that they can't forget, that is key. Whenever I'm taking folks in for a lobby day or something like that, I always tell them the one thing we want to be today is memorable. Lawmakers will have a dozen meetings. They'll forget most of them. I want you to be the meeting that they can't get out of their head 3 weeks from now. That's what we can all do, because we all have access. We all hear these stories one way or another. So we can all be that can't get it out of my head anecdote that someone in a position of power, regulatory level, state, federal, legislative level, is not going to be able to forget.
Well, you gave us two of those stories today, that's for sure, Alex.
Sure did. And that is fantastic advice.
Yeah.
Jason?
I mean, we're up against time. I'll turn it over to John, echo what Alex and Melissa said. And I really like that, right? Be memorable. And what was it? None of us get out of this life alive. What was that, Melissa? I like that one too. Yeah, that was good. Go ahead, Joe.
Spoiler alert, we're never getting out of this life.
Well, look, I'll be brief and just say patient voice is central to good evidence. And today, now more than ever, we need good evidence to have discussions about the healthcare policies and current debates. So let's keep that going and look forward to further conversations.
And special thanks to you, Mike, and Kelsey behind the scenes here. Backstage, as I've now learned, is a new Zoom feature. So thank you for hosting this.
Well, thank you to all of you. This has been, just a wonderful continuation of that earlier discussion. But it's interesting to me that we really did hone in on some very different themes this time, in terms of foundational issues, balancing patient access, really refining our messages as patients and making sure that that voice is heard front and center. And John, even making sure it's heard through our research, our intellectual pursuits, to make sure that it really helps educate policymakers. These are really critical, pieces to pull forward. And I know we're doing a lot of webinars moving forward towards the end of this year. And so, again, the invitation is always open for this panel to come back. And we appreciate all your insights and the work that you do on behalf of patients. Thank you. And with that, we will adjourn.
Thank you all.
Thank you, Mike.